Hey everyone, this is Derek Erstead with Surgery Snapshots, and in this video we are going to review pylorus-preservation versus classic-style Whipple techniques. There are three main concepts in this video. First, I will review stomach anatomy and physiology. Second, we'll talk about vascular ligations that will happen with any type of Whipple technique as they pertain to the stomach. And then third, we will compare and contrast performing an antrectomy versus pylorus-preservation. Finally, it should be noted that many of these concepts are also relevant beyond the Whipple, and they apply for any type of procedure that involves the stomach. Thank you for watching. Okay, so let's first talk about the vascular supply to the stomach, which is unique because there are 5 separate blood supplies. I have shown the arteries in red and the complementary veins in purple on the image. On the lesser curvature of the stomach are the right and left gastric arteries and veins, which communicate through an arcade. On the greater curve of the stomach are the right and left gastroepiploic arteries and veins that also communicate through arcades. Finally, there are the short gastric vessels that insert into the fundus and the cardia of the stomach. Now, because the stomach has excellent and redundant blood supply, and it is made of thick muscular tissue, from a surgeon's perspective, the stomach is thought to be one of the most forgiving alimentary structures to manipulate either with transection or anastomosis. Now, regarding the nerves, the primary parasympathetic supply to the stomach, which is essential for gastric motility and physiologic activation such as acid production, is served by the vagus nerves. The left vagus nerve of the esophagus transitions to the anterior vagus nerve of the stomach, which is shown with the solid yellow line, and the right vagus nerve of the esophagus transitions to the posterior vagus nerve of the stomach, which is shown in the yellow dotted line. Now, importantly, the vagus nerve runs near the lesser curvature of the stomach, and they have efferent extensions that traverse towards the greater curvature of the stomach, as shown with these yellow arrows here. Because the vagus nerve runs along the lesser curve of the stomach, it is thought that perhaps the method by which the greater curve is mobilized during an operation may have minimal impact on gastric motility and physiology because the greater curve is geospatially well away from the primary vagal branches. So in this regard, the idea of hugging the stomach during your mobilization may, in theory, be inconsequential towards the mechanics and physiology of the stomach. Okay, so now let's take these basic concepts into consideration with the Whipple procedure. So when we perform a Whipple procedure, there are 2 approaches towards the stomach. One approach is the Pylorus-Preserving pancreaticoduodenectomy, in which the stomach is transected at the level of D1 and thereby preserves the antrum and pylorus, as shown with the green line here. A second approach is referred to as the classic-style pancreaticoduodenectomy, in which the stomach is transected at the level of the antrum and is removed with the specimen, as shown with the blue line here. So let's take a minute to discuss the potential advantages and disadvantages of both of these approaches. I'll first focus on the pylorus-preserving approach. The theoretical advantage of the pylorus-preserving approach is that the entirety of the stomach is retained and thereby preserves more normal alimentary mechanics and gastric physiology. Importantly, the antrum of the stomach is the primary source of G cells and gastrin production, which then feeds onto the parietal cells in the fundus of the stomach for acid production. Therefore, it is likely the case that with pylorus-preservation, the surgeon is also maintaining more normal gastric chemical physiology. A second potential advantage is that maintenance of the pylorus may reduce biliary reflux from the afferent pancreaticobiliary limb after Whipple reconstruction. Biliary reflux is quite caustic because activated bile salts are particularly erosive to the esophagus. Now, perhaps due to both more normal anatomy and physiology, there is some data that supports that pylorus-preservation with a Whipple procedure may be associated with long-term better nutritional outcomes, but this is debated. Now, on the other hand, there are some potential disadvantages to the pylorus-preserving approach. In multiple retrospective analyses comparing pylorus-preservation versus classic-style Whipple, the pylorus-preserving approach is associated with higher rates of delayed gastric emptying. A pylorus-preserving approach might also be more technically nuanced because depending on the surgeon's dissection, it is possible that at the level of the pylorus there can be denervation of critical vagal branches and also mild ischemia. These factors may contribute towards whether or not a patient experiences DGE. Now, when comparing pylorus-preservation to a classic-style Whipple, there have been no observed differences in survival or nodal yield. However, depending on the indication for the Whipple procedure, if you are dealing with a tumor that is invading in or around the very distal stomach, a pylorus-preserving approach, in theory, may run a higher risk of a positive margin. Okay, so now let's talk a little bit about the classic-style Whipple, in which you also perform an antrectomy. So in this approach, there is a higher risk of biliary reflux esophagitis because the connection between the jejunum and the stomach is free-flowing without a pyloric valve to mitigate backflow of bile. Many surgeons will develop their own approaches to optimize the GJ in order to attempt both mitigating bile reflux and also to optimize forward flow of food contents Things that surgeons will consider are controlling the size of the gastric jejunostomy, placing the anastomosis on the posterior dependent surface of the stomach, and also attempts at creating ideal angles for efferent limb outflow. However, I will say that most of these practices are based off of anecdotal experience rather than well-defined studies. A second potential disadvantage of the classic Whipple is augmented GI physiology. With the antrectomy, the majority of the G cells have been removed, and therefore there may be less acid production to help with digestion. Nonetheless, it is the case that patients with a GJ are often recommended to take a lifelong PPI to mitigate the risk of marginal ulceration at the GJ, as stomach acid will still be produced. Now, with pylorus-preservation, it's interesting because there is preservation of the G cells in the antrum, as well as the entirety of the vagal nerve, which stimulates acid production, and theoretically you may have enhanced production in the stomach with pylorus-preservation. Yet, due to the preservation of the pylorus, there is more controlled release of stomach acid into the jejunum, and therefore the risk of marginal ulceration is going to be lower. Lifelong PPI therapy is not necessary. However, some surgeons may still recommend it based on their personal practice. Okay, so now let's look at some vascular considerations with the Whipple procedure. Regardless of the approach, you will ligate and transect both the right gastric artery and the right gastroepiploic artery, thereby removing both distal sources of blood supply to the stomach. Yet, due to the excellent redundancy, the stomach can easily handle this hit in most cases due to collateral flow. Now, when you perform a greater curve mobilization, which is the other augmentation of the stomach during this operation, there are two approaches to this. So one approach is to splay out the stomach and the omentum and find that bare area between the greater curve and the gastroepiploic vessels. This anatomic space is easy to identify, and in most cases there are minimal attachments to take down in order to gain safe entry into the lesser sac for your mobilization, and I've shown that here with this dotted blue line. However, when you do this, you also transect all collateral flow from the gastroepiploic perforators to the greater curvature of the stomach. Now, we know the stomach can handle this because of empiric observation, and many will not take this into serious consideration. However, it is undeniable that there is a large swath of gastric tissue that theoretically is dependent on long-distance perforators, as I've shown with this orange circle. A second approach is to mobilize the greater curve of the stomach outside the gastroepiploic vessels. And in this scenario, although the right gastroepiploic artery has been transected, in theory, there may be collateral flow coming from the left side through the arcade for direct greater curve perfusion. This approach, however, can be more technically challenging, particularly in obese patients, because you are forced to find a more nuanced bare area to safely enter the lesser sac. Although there is no major literature justifying either approach, I do believe that attempting to preserve the gastroepiploic arcade for left-sided perfusion to the greater curve of the distal stomach may provide potential value to patients. Finally, what has been shown, however, in the literature is that ligation of the left gastric vein, also known as the coronary vein, is associated with higher rates of postoperative delayed gastric emptying. Now, ligation and transection of the coronary vein is necessary in some pancreatic operations depending on its location of insertion into the splenic or portal veins, as well as the extent of tumor involvement. The theory here is that the coronary vein is often very large and it provides excellent venous drainage. Therefore, ligation of the vein may result in gastric congestion that has adverse consequences on emptying. Okay, so that is my summarization of some key considerations about vascular supply and nerve innervation to the stomach as it pertains to the Whipple procedure. Thanks for watching.